My name's John. I'm a medical oncologist in Vancouver, Canada. I've been practicing here for about 4 years. Before that, I was in Houston, Texas, and I worked there for a little bit. So I know a little bit about the American system, but mostly practice in the Canadian system. It's great to have this international collection of people so we can kind of share different experiences. I mostly treat colorectal cancer, and I work with CCTG, which is our Canadian cooperative group. So in Canada, we only have one cooperative group, and we participate in trials with different groups. So with the French or Australians or the American cooperative groups, and we kind of work together with other groups. So I can share a little bit about how things work in Canada and hear a little bit about how we can learn from each other. And yeah, it's great. And Manju, thanks for inviting me. Manju, I pick Manju's brain whenever I have an idea, and she gives me some good insight. It's great.
Yeah. Thank you for that. Yeah. Okay, I think we can start.
Sounds good. I'll share my screen. We've got kind of 4 posters that we can go through, and we can kind of see where things go. And I'm not sure if you guys have seen these posters already and what's your experience with them. And so we can kind of walk through kind of my approach to them and your approach to them, and kind of see what we want to talk about. There's lots of ctDNA stuff at ASCO this year, which is great. It's kind of coming into the forefront and starting to transition into the clinic instead of just the research assays. So it's great. The first one that this group has presented quite a few times, their data at Henriksen. They've published it in JAMA Oncology, and then they've done a number of cohorts where they looked at stage 1 through 3, and this is really looking at just the stage 3 group. So patients who had stage 3 cancer, had their cancer resected, and looking at the results as far as using Signatera assay as a metric for risk of recurrence. Can you guys see my screen okay? So I hear everybody was on the call earlier and talking about Kaplan-Meier curves. Is that right?
Yeah.
Yes.
Sounds good. So you guys have seen these curves and talked about them, but those are really nice curves when it comes to oncology, of seeing something that is real and believing, how much difference there is and how useful this might be. And so seeing the ctDNA negative group, much better prognosis than those who are positive. So most people who are ctDNA positive having a recurrence. It's interesting that they don't, in this cohort, they're not all recurring, which makes you wonder about maybe some false positives there, which we'll talk a little bit about some of the other things they looked at in here. Did you guys talk about hazard ratios at all?
A little bit. I think Natalia and Michelle were not on that call.
So Kaplan-Meier curves, basically, it's the proportion of patients who haven't had an event. And sometimes these can be used for lots of different things. We use them in oncology to talk about whether someone hasn't had their cancer come back or whether it hasn't grown. People who study like how long dishwashers last and things, actually industries use Kaplan-Meier curves too to talk about failure of like parts. So they're really useful to look at when something happens over time. And so what you're looking at here is, if the curve goes down at some point, it means that someone has had something happen. And that, in this case, it's their cancer came back. And sometimes you'll see these little ticks. A tick means that someone is censored. So not everyone enters into, or not everyone has the same amount of follow-up, which means how they did and what happened with their story for as long a period of time. And so there might be someone who was the very first person on a study, and we might know what happened to them 4 years down the road. And there might be somebody who was only on the study for 6 months, and it's just because they were much later. And so we don't know what happens in their future. And so we censor their data at the point where we don't have any more follow-up. So if you see those little ticks sometimes, that's what those are. And that's also why sometimes you see that the curves, like up here, each time it drops just a little bit because there's lots of patients that are included. But if you go down here, there's the drops are bigger because there's less patients. And so if a patient has something happen, it's a larger proportion of the patients there's still data available for. Any questions about that?
That's good.
Sometimes people will put this, they're very confident in their data. So they've got the 95% confidence intervals on here, which is the outline, the blue and the gray. Oftentimes they're not this far apart, and so people don't always include them. It's nice to include them. The real, knowing if something's real is in the statistics. This is called a log rank test, and so the hazard ratio says how much more likely something is to happen in one group relative to the other. So it's 7.2 times more likely to have a recurrence if you're in the blue group here.
Sorry, one question,
Yeah.
and as non-scientific person, do the drops mean that the patient died? That was my understanding based off our last.
That was based because they were plotting progression-free survival and overall survival.
Oh, okay, thank you.
Yeah.
It depends what it's meant to represent. So recurrence-free survival, they count an event as the cancer has come back or someone has died. Sometimes, if someone is older, they might die from another reason, and that might be counted as an event, even though it had nothing to do with the cancer. And so that can also count as an event. And so sometimes you'll see things where people describe, they might say recurrence-free survival versus cancer-free survival, or that they might do different things. So that way the curve doesn't drop if someone dies from another reason or has something else happen.
Very helpful, thank you.
And then on the bottom, they often have these numbers here. This is to give you a sense of how many people are still left in the curve at that time. So remember, if we only know what happened to someone for 6 months, well, then at 12 months, they're not really contributing any information to our knowledge. And so down here, they'll include that information. These are the number of people who are at risk, meaning they could have something happen to them. This is really important to know kind of how long the follow-up is, because if someone did a study where you only followed people for a couple months and they've got some data out here, it's not really useful because you're not really comfortable in trusting the data because it might only be 1 or 2 people that are providing information. So this is another useful thing. Sometimes it's included in the curve, sometimes it's not. So this is really nice split. We see very similar hazard ratio with lots of the different tests. So this one was using the Signatera, which is where they take the tissue and they do exome sequencing, which means all of the parts of the genome that make functional parts of a protein. So the genome is really big and there's lots of stuff that's kind of quiet in the genome. And so an exome is kind of more of the parts that we know do something. The genome is still really useful, but we don't really understand a lot of the spaces, and there's a lot of filler spaces. And so what they do is they find the particular abnormalities and they make custom ctDNA tests for patients based on what is in the cancer. But this hazard ratio is, you would see this in other tests, not just the Signatera. You see something very similar for all the different assays. It's always kind of around this kind of 5 to 8 mark for stage 3.
John, can I ask a question?
Yeah.
So the previous poster that we were looking at, the hazard ratio was 1. Why is it in for these kind of tests, it's like close to 10 or something like that? What makes the difference?
I'm not sure what the previous poster was. If it was 1, it would mean that there wasn't much difference between the two.
But what Dr. Grisdorf was saying was that anything below 1 said that the chance of that being good was higher, and then anything that crossed over, beyond 1 was meant that whatever the condition was, that was not good for survival. So the hazard ratio was 1, whereas in here the hazard ratio is 7. So is that the denominator and numerator are very different? Is that what makes it so high?
So you could also give this hazard ratio differently. You could say, so right now this is saying that ctDNA positive patients have a 7.2 times more likely risk of the cancer coming back.
Okay.
But the other way that you could do it is you could give a hazard ratio of like 0.18 or 0.2, it would come out to, for the hazard ratio of ctDNA negative compared to ctDNA positive. So it's actually just 1 divided by the number, regardless of whatever the number is, and that'll tell you what the flip hazard ratio is.
Okay, thank you.
So depends how you want to tell the story, really.
So basically, by looking at the survival curve, you could with relative confidence tell the patient, if you've stayed negative for a year, let's say 12 months, you can start spacing out your tests because the chances of the cancer coming back are lower and lower and lower. So thinking about the economic burden for the patient, right? If you don't have it in your insurance covered, because in the United States, it is covered, but internationally, most patients are paying for the test, and it's about $950 US. So every time you repeat it. So,
yeah, it's interesting here. That's a good point, thinking about when do you do the test. Most recurrences happen in the first year, which you see nicely that you're getting a lot, but you do have kind of this spread out here. And most of the trials that look at surveillance, and the NCCN guidelines have a lot of CT scans, but a number of the international trials that have been done looking at surveillance, they recommend now surveillance. Actually, the most recent guidelines, most places suggest a CT scan at 12 and 36 months. Because there weren't many more cases that were found by doing additional CT scans. So if you do the CEA plus that, it was very similar. There's downsides to doing the scans from the cost. I mean, there's always the risk that you might miss some, and so it's a bit of a debate about what's the best strategy. But that 36 months is kind of a magic number, and there's someone named Manish Shah who showed a really nice curve, and what it was looking at when the recurrences happen, and basically you see this curve. If you look at my arrow, it's kind of like this, and then it comes down really nicely around 36 months. So like you said, that might be a good way to prioritize if people are having to pay for it, thinking about when it's most valuable.
Yeah, I don't mean changing the scans or the NCC guidelines, that stays as it is. Just thinking about the incorporating the ctDNA testing, that maybe you can space it out a bit.
Yeah, I think it's a great point, because we know that in the US, like I'm stage 3B, I only get annual scans. But there are people with stage 3B who get scans every 3 months, which is like way unnecessary, like really that's, but I think NCCN guidelines talks about every 6 to 12 months for the first 2 years, and then every year for the next 3 years. That's what they say. But, there is always both extremes, right? Somebody who uses it too much. Yeah, sorry.
No, it's good. It's nice to talk about. That trial came out, there was a big trial. It was at ESMO. It was the last one in person, whenever that was. That was the surveillance one where they did the 12 and 36 months. So in BC, where I'm from, we were doing a scan once a year for 5 years, and then we didn't really like the 12 and 36. We were worried people might fall through the cracks, and so we did 12, 24, 36. And then if everything's good at 36 months, talk about not doing the last 2 years, but it kind of depends on the situation and if there's anything you're following on the CT scan. But lots of different places have different guidance. So the next graphic that they have was just looking at the recurrence rate in those who were ctDNA positive versus negative. 80% of people who were positive recurred versus just 18% in the no recurrence. So just a different way of looking at this information. Obviously, it looks really impressive how much difference there is. Most of these patients, they don't give too much of the information about patient level of who got adjuvant therapy. I think what's concerning is when you look at the 20%, and if you think that all of these patients got adjuvant therapy, that most of them, 16 out of 20, are going to recur with our current treatment. And so I think this is an area where we're hoping we can try and modify. And there's a couple trials that are coming that are looking at trying to intensify treatment, thinking about things like FOLFIRINOX, to see maybe we can move this up and make it so more patients that are ctDNA positive that are really high risk can be cured. And maybe in this group, you might be able to limit the toxicity.
John, I had a question. So these, they're not following it sequentially, right?
They are, but it's a bit opportune. Oh, this is just the first one.
Yeah. And I was kind of wondering whether, the 20% or, the ones that didn't recur or came back, I was wondering whether with repeat testing, were they getting the same results? And that would have changed that bar graph very differently, right?
That's a good point. I also wonder about this 18% and the subsequent testing. What I really like on this poster, and probably the main takeaway that I had, was and it was hard to take if you just walked up to the poster to take this away, but they looked at the amount of cell-free DNA, which is both the stuff from the tumor and the stuff from normal tissue. And they looked at people who were ctDNA negative versus positive, and they saw that there was actually more DNA floating around. And what they looked at was, in this group, if you did like a subsequent test before adjuvant chemotherapy a little bit later, the amount of DNA actually fell. And they postulated that this was actually because there was normal tissue damage because of surgery. There's lots of tissue that's healing and damaged, and it's releasing a bunch of normal ctDNA or cell-free DNA. And that might actually be kind of drowning out the positives.
Mm.
And so maybe if you get a negative and you're close to surgery, you might need to do another test a little bit later, because some of these patients were within 3 weeks. They were quite close. We don't really know when the best time to test is. What has your guys' experience been when you talk to other people about when they're doing it after surgery?
Yeah. We had a lot of debate with the team here because it was the first time they were using it. So everyone had questions and no one really knew. And this was in a little metastatic setting, right? So a step forward, let's say, compared to these people here. But what they decided to do was to do testing for 3 to 4 weeks after surgery, and then do another test 4 weeks after that, and then 6 weeks after. And from that point, so it was 4 weeks, 4 weeks, 6 weeks, and from that point, every 3 months.
Mm-hmm. So in Colorectal, what we generally see is that many people suggest 4 to 6 weeks after surgery, no more than, not less than 4 weeks. That's what we have heard. And then I see that some trials, what they've been doing now is like, they'll do one test and then repeat in 1 month. Mm-hmm. And then both of that together, they consider as, starting point as whether the patient is ctDNA positive or not. So I thought that was interesting that they were doing it to see whether, 1 month later they would get the same result, or whether, what was positive would go away or something like that.
Yeah, that's a really good, my experience with it is, again, in the metastatic setting. I was on FOLFOXIRI for 4 months, and we did a ctDNA right before surgery when I was off chemo for 4 weeks, and it came back negative. And then we did one 4 weeks after surgery, and it came back positive. And so we thought that maybe the chemo had suppressed the it wasn't shedding as much. And so or we got a false negative the first time, and then the assay became more sensitive with the second test.
That's a really nice, they have data that really supports that as well. Very similar kind of story with on chemotherapy, not really knowing how to interpret it. I'm just jumping ahead to their figure because I just what you said really matches nicely with what they were describing. So they saw a lot of people who on adjuvant chemotherapy during the actual chemo portion, they became negative, but very shortly thereafter they were positive. And it wasn't really as informative, that section. There were some people who just stayed positive, but that during, it was really hard to interpret. And it was kind of the afterwards that shed.
And I've heard that like with, before Signatera was available, lots of people were using Garden 360. And we know that from Colorectal data, what we have seen is that a lot of people who are on treatment, Garden usually comes back negative. Or, it would show TP53 at 0.1, mutant allele frequency or something like that, which, you don't know whether to believe it or not. But with Signatera, what we have seen is that some people, you can see they started out after surgery with like 20 MTMs or something. Then they go down to like 6 or 7. And then through the course of chemo, when they're doing every 2 months, then it drops down really. And then after the end of chemo, it stays 0. And for some people, then it comes back after, 6 months. But for many others, it doesn't come back. So that must be also a difference between, for whom it comes back and for who it doesn't, right?
And I presume they don't say it in the poster, but it would be great to know where the recurrence is.
Because I think that's, again, something that we have a lot of discussion in Colorectal. People generally think that those with lung mets, this test is not very good because lung is such a bad shedder of ctDNA. And then liver mets and peritoneal mets and all of those show better. But so this poster would have been much more useful if they had actually shown where the recurrence was, right? That would have been awesome.
Yeah, the peritoneal mets, I had seen something at GI ASCO where they did not seem to shed very much. Have you had people having detectable? Yeah.
Yeah, we have a couple. Yeah, we have a couple of people who the only thing that showed up was Signatera, and they didn't see anything on CT scan till they had little ascites or they had some other procedure and they saw peritoneal mets. So that was kind of good because I thought that nothing could detect peritoneal mets. And then I think Dr. Kasi had a presentation where he was talking about liver the most and lung the least and peritoneum in between. So
yeah. Liver definitely makes it a little bit easier to detect. think that's most of kind of figure 1. Figure 2, they looked at people who were ctDNA positive after their surgery and whether they recurred or not, and kind of when the test changes and what it looks like. And so this is a swimmer's plot. Have you guys talked about a swimmer's plot before?
We did talk briefly, but not too much. That paper didn't have one. So this will be a good time.
Yeah. So swimmer's plot is trying to give kind of the narrative story of what happens to each patient, and you can look at it and see. And so along the y-axis here, you're seeing each of these is a different patient that's represented by a number, and this is time, and they're telling you the story of what they're doing. So the light line is the follow-up, meaning you know what happened over that time period. So some of the patients aren't followed quite as long, so you don't know as much. And then you've got different tests here. So the black tests being ctDNA. It's not a very good graphic to have dark spots that are light or small versus not so small. It's very hard to tell.
Yeah, that was just so.
Yeah, so I feel like it wouldn't have done that, but
Yeah.
They all seem negative. They all seem big.
yeah. It's very hard to take anything away from this.
Yeah, you can't even tell, even side by side. Maybe this one, like this one is probably small. This is the only small one, or maybe that one.
So normally on a swimmer's plot, what you would look for, I would have made this a different color, and then you would see, okay, they're negative, and then you can see when they're on their, like this would be adjuvant chemo. Oh, adjuvant's the gray, and then this is when they're on chemo for maybe metastatic disease. So this would be a recurrence here because they're in red, but that ctDNA looks the same color, but it might just be the difficulty in interpreting this. So it's supposed to kind of tell you the narrative and the story about what's happening for each patient. And they're quite helpful when you've got a smaller group of patients. If you've got 1,000 patients, this is kind of hard to interpret because there's so much going on, but it's a nice way of showing you what happens over time if the colors allow you to interpret. I'm not sure what else to take away from this, to be honest.
Yeah, it would be nice to see chemo and then negatives, but
yeah.
I mean, this one is just really hard to see anything.
Yeah. We talked a little bit about this, about the chemo, lots of people clearing and then coming back a little bit later and it making hard, but some people not clearing. So this was a curve that was looking at patients after their adjuvant chemotherapy was done. So that hazard ratio is really quite shocking. So if it's positive after adjuvant, it's much worse. When you look at the curves though, they're actually not that much different in the shape. It's the ctDNA negative almost that is driving it more, that they do really well if they're negative once they're done. But if that 100% of people recurring, if they're positive, is the part where we hopefully can make something a little bit better happen. And then they looked at the kinetics of the ctDNA, and so what they were looking at is how much change there was over time for people who had a recurrence. And they kind of grouped the patients as fast recurrences versus slow recurrences, but there wasn't too much more that they did with it. So I wasn't really sure how to add that in. I mean, it can be an anatomy thing, it could be a tumor thing. There's lots of different things that you could draw from that. But needless to say, I think that lots of people have different trajectories. I don't know if you guys have any other ideas of how to use that.
I guess that if they inform where the location, the anatomic location of the metastasis, because it could be that you're shedding more and picking it up quicker because it's in the liver, and then if you have a slow growing mesh, because we know, like, this is anecdotal again, right? So from various patients in Colorectal, for instance, is that they seem to recur very quickly in terms of ctDNA when you have a long met, because the time from when the ctDNA becomes positive to the confirmation in scans is very close, whereas when you have a met, I don't know, in the liver or even lymph nodes, like retroperitoneal lymph nodes, you have a slower release over time until you can pick it up in the scans, and normally what you see is a peak. That's what I noticed in a few people, but again, it's anecdotal, so it would be nice to have a proper study.
Yeah, and I mean, seeing this, the different figures, I almost even feel that like Tana had presented this a similar thing at GI ASCO, and I felt that they wanted to have enough new data to put in the poster, so they just added some random figures. Sorry to say that, but like the things that we wanted to know about, like site of recurrence, they did not add that.
Yeah, and then I wonder that if I were the one dealing with a stage 3 diagnosis, looking at the ctDNA, if I was one of the ones with a positive result, and even after adjuvant and everything, I would question whether my original staging was right, or if it is that, okay, the only thing we can spot in scans is a local, tumor, and maybe some lymph node compromise locally as well. But then whether there is a microscopic metastasis that you can't see, that's another thing. When you are, especially when you're one of the, with that fast kinetic kind of, you would wonder, was it that it was already there? I don't know.
There's often, people who also present with their diagnosis who it's the first time we've done a CT scan, and so we find something in the lung where it's a tiny little thing, and it can just be something normal, and we often end up doing a CT scan in 3 months and saying, okay, well, if it's changing, then we'll know, but it might just be that it's a nodule because, of a prior infection or something like that, and I think this gives a little bit of clarity around those situations.
And then I was thinking that, like, with the IDEA results and all of that, they say that, like, 28% of stage 3, even after chemo, will progress to stage 4, right? So my question would be, like, is this test really picking up that group of patients that, the chemo and surgery is not going to prevent them from progressing to stage 4 anyways, right? So maybe it's the other group, like the 75%, who are cured by surgery and who will be cured by chemo, that is really being picked up here, right? Which we can act on. The remaining, like, almost 30% will anyway progress, right? Like, nothing we do is really going to change their outcomes.
Yeah.
I think that's one of the really important things with ctDNA that is still to be borne out of. It's a good test from prognostic and information for patients, but if we can't change anything with it, and so prognostic marker means that it tells you if someone's going to have their cancer come back or if they will die from their cancer, but a predictive marker means you can actually act on it, which is really what we want, to be able to change their care so that way things happen better. Or on the other side, to think, can we prevent toxicity for patients who really don't need the extra chemotherapy? So I think we still need that before it's kind of, I think there's this steaming ahead train, and ideally we can get all that information. We're going in the right direction. It's just adding in that extra piece of how do we use this to actually make things better.
And I was also thinking that those people who are actually positive, maybe what we need to do is a more thorough genomic profiling, and to see if, in addition to what we would give them, like FOLFOX or the next line FOLFIRI here in the US, maybe they can find like a BRAF mutation or something else, and then combine that with the chemo. Maybe that would make a difference, right? Yeah,
that's a really good idea. Good group to try and target.
I would just one experience again from our founder, Dave. He was diagnosed stage 3, and he unfortunately after surgery and 6 months chemo had a recurrence in his lungs, and so they did some more chemo. They did watch and wait, and so during the time of watch and wait, where 3-month interval scans, they did not, because his CEA was not illuminative for him, it stayed, around 1.2 the entire time. They did not know there was a liver tumor growing, and it grew within those 3 months to 7 centimeters, obstructed his bile duct, and he died because of that. And so I think sometimes ctDNA could be a useful indicator for those that maybe are on watch and wait, or in between the scans. That's just from one experience.
Totally agree with you, Asal, in that. And even we had, and I think it's a really difficult point to make, but we have to take it into account from the patient perspective. I always remember Leslie in Colontown. She has a mucinous tumor, I think, with perimetastasis, and she said that this test was the only thing that could pick up the recurrence for her tumor, because it wasn't showing in scans. However, they still adopted this watch and wait, behavior. And today, knowing that she was having a recurrence, peritoneal recurrence, she was saying, I should have pushed for an exploratory laparoscopic surgery, because it was the only way to know where the mets were. And I think that's another thing. I would love to see that clinicians, instead of, saying, oh, I'm sorry, you're positive, so we know chemotherapy won't help. I wish that a lot more clinicians could go with a more aggressive, especially for younger patients, a more aggressive behavior, and say, okay, let's see, let's scan everything, let's try to find where it is, and if you can't go and have your surgery, try to have surgery, because from what we are seeing, maybe chemotherapy cannot clear it out, but adding another targeted therapy, as Manju said, or maybe going aggressive with surgery, if the patient is fit enough to tolerate a surgery, I think we need to push more, because we constantly see stories where people, by pushing harder and getting more aggressive treatments, they do live longer, and they do live better as well, because the time you're off chemotherapy, you're also in better shape. So I think that's an important point. I would hate to see teams, saying, we're not going to do anything just because we know that if you're positive, there's nothing else we can do. So
I agree. I think with young patients, I mean, again, defer to everyone, especially our medical specialists here, but I think we have to do aggressive monitoring and aggressive approaches, because again, thinking of, the experience with my friend, if they had caught the liver tumor early, maybe they could have ablated it, maybe surgery. I mean, he was a marathon runner, right? So yeah, completely agree with you.
Yeah, I think that's one of the things that we actually suggest in Colontown, is that, especially for people who use like MRD testing like Signature during surveillance, if they turn positive, to go back and have a re-look at their previous scans, because they might have seen a shadow in the lung which they thought was nothing, but with the light in the light of the positive ctDNA, maybe you could have a different radiologist look at it and think whether that could really be cancer. And then again, the thing is that I think there is a lot of hesitation, because I know that people who believe in ctDNA believe it like a lot. And the people who are skeptical about ctDNA, they're like, no, you have to see something on scans before we'll do anything. So I think we have to convert those skeptics into believers. Otherwise, it's just really not going to work.
And Dr. Loree, what's your opinion on this? Because we are in very similar, exactly the same situation. Like if liquid biopsy tests positive, our doctor says they won't do anything. I guess it's because not a standard yet. So what's your opinion on this?
No, I think it's a bit more nuanced than where we're kind of landing. I think that there's a discussion that needs to be had. I think if a ctDNA test is positive and someone's had appropriate scans at the same time and you can't see anything, then I don't know that if there's nothing that you can do. Sometimes biology is something that we can't get around, and so it might be that waiting and watching is the way to go if you can't actually see anything. I think the laparoscopy is an interesting question, particularly for certain mutations, like if there's a BRAF mutation, or if there's been signs of that before. But I think it needs to be kind of more of a discussion, because there might not be something that can happen. It might not be that they're saying, no, we won't do something. It might be just that if you can't see it and you can't act on it, then how is it changing your care? And that's an important thing, thinking about value of test as well. If it's not changing the care, then it's, how are you using it to improve things?
I kept wondering, like many people have this thinking like, if I can't see it on the scan, I can't do anything because I want to monitor how it shrink and everything. But like those liquid biopsy, if they give you a value or your CEA is a good indicator, you can also follow that, right? But it seems doctors are reluctant to follow that.
I think that could be a discussion about the goals for patients as well, because you could start some chemotherapy maybe in that setting, and that might, for some patients, that might be what they want to do, and that might make sense. And other patients might say, you know what, I don't want to be on chemotherapy. You know, I often have discussions with patients who want to be on a chemo break because of toxicities they've had before, or, you know, pre-COVID, it was travel. That was a big, you know, things like that. So I think there is a discussion there to have, and there's lots of different ways that that can be carried out in a patient-centered way that's taking into account both options.
Yeah, and I also thought the other important thing to keep in mind is that when we see so the general idea that we have is that, you know, if something shows up on ctDNA and is not showing up on the scan, it means that there is fewer tumor cells, right? And the assumption is that if you treat that tumor when it is so small, then the chances of resistant clones may be lesser because the total tumor cell number is fewer. But the thing that we don't understand is that is treating things that early for the, you know, the cancer that shows up early, you know, shows up positive on ctDNA, is that biologically so distinct and not, you know, in general, more resistant to any kind of treatment that treating it early won't change the overall outcome, that the patient would die anyways, then doing that treatment early is just giving them more toxicity, right? I think that's what we're waiting for clinical trials, that if you treat when you see something on ctDNA, is it really changing the life, the overall survival of the patient? And I think once we have that information, I don't think anybody will hesitate in treating the patient. But right now we don't have that information. And it's quite possible that those patients who are ctDNA positive so early, you may not have anything right now that's available that can actually cure them, right? I thought that was another thing to keep in mind.
Yeah, I think that's a good.
Yeah, we need a clinical trial.
Yeah.
Yeah.
Clinical trial, you know, there's lots of these posters that are these retrospective studies, but nothing beats that trial of telling us and building the data. And that helps for getting reimbursement too in other systems.
Yeah.
Yes.
And
we
it's
have
also sending a really important message, because if we run all these trials and the conclusion is that graph on the top showing that no matter how much chemo you have, you're going to become positive again and you're going to progress, then the big message with, like, you know, all caps and red background is we need new drugs.
Yes.
Because we don't have enough drugs, because that is like the story in CRC ends with the lack of drugs. Like you're around 3 or 4 combinations where toxicity is inevitable, quality of life is awful, and then we don't have any more options. So I think that it's great to be excited about these new biomarkers and everything, but we don't, like, we need to keep sight at what is the most important thing, which is development of new therapies, because we don't have enough.
Agree.
So then, shall we go to the next one?
Yeah.
Or you want to look at the conclusions?
Oops, I closed it. Do you want to look at the conclusions? What are your guys' conclusions? What do you guys take away from that?
I think it's more like a descriptive thing, right? Like it didn't tell us things that we didn't know really. Yeah. And to Michelle's point, like so Aparna Parikh at MGH has this Stand Up to Cancer trial, the ctDNA trial, where people after adjuvant chemotherapy are tested for ctDNA. And then after that, they get the next line chemo or targeted therapy if they're BRAF positive, or if they're MSI high, they get immunotherapy. And then they're looking at clearance. So it'd be kind of interesting to know that 30% who progress to stage 4, how many can they save with these different treatments? And if it's like half, then that's good enough, right? But if it's like 1%, then probably not. But yeah, I think we need more trials. And, you know, the trial that you're planning would also be helpful, right? Kind of.
Yeah.
Yeah.
So we're planning a trial that's for patients who have had their metastatic lesion in the liver removed, and looking at ctDNA and trying to use that to personalize the treatment for the really high risk group versus, less chemotherapy potentially if it's lower risk.
I think for now the conclusion is if you're negative, you are lucky and you can probably de-escalate treatment. And I think that that's really important, because a lot of people are getting chemotherapy then
It's not
going to help. So
I don't know if we can say that though, because all of those patients got chemo that were negative. So I hope that's true. I really do.
Oh, sorry. Yeah.
I really do. But that's where I think COBRA is going to be really good. And I think so we have Dynamic 3, which is our stage 3 with the Australians, and it's looking at de-escalating. There's like a ladder where you go up the ladder if you're positive and down the ladder if you're negative. And I really hope that those are good trials that give us the answers that we need. This was a poster that was presented by the Japanese groups. They have a trial, Circulate Japan, which is kind of their platform study for looking at ctDNA across stages. I'm just going to zoom in.
I think aren't they planning a US? They're planning US Circulate too.
Yeah, Circulate US is a trial that's going to look at ctDNA in stage 3 and similarly kind of adjust the chemotherapy, as Natalie was saying, to try and make it better for patients as far as less toxicity if you're low risk, or more intense chemo if you're really high risk.
By the way, you mentioned adjust the adjuvant chemotherapy. So what are the options? In my mind, I don't know there are many options of different adjuvant chemo. What are you thinking of when you say adjust the adjuvant chemo intensity?
Yeah, so if we're talking about stage 2, then sometimes people use no chemotherapy, or capecitabine or 5-FU by itself, so just the one drug, or for really high risk patients, FOLFOX or CAPOX as the doublet, and that depends on the risk of the cancer coming back. And in stage 3, though we say, you think about 3 months of chemotherapy if there's only less than 3 lymph nodes that are involved. So basically T4 and N2, we think 6 months would be good based on this trial called IDEA. And if they're not that, then they could do only 3 months. And so there's the duration. Some patients, though, who are older might only be able to take capecitabine. It might be that they have a lot of other health issues. And there's a really nice poster by Sobrero et al. And they've made it into a publication. And it's got this great graph that shows the risk of the cancer coming back based on like T2, T3, T4. And it's got all of the N combinations. And it's great for discussing with patients, because you can see how much benefit you get from the fluoropyrimidine, so the 5-FU or capecitabine, from doing 3 months of the doublet or doing 6 months. And there's a lot of people who are pretty low risk where going to 6 months of doublet chemo doesn't add a lot. And even some that are really quite low risk where it's mostly the capecitabine or the 5-FU that gets you most of the benefit. And so if somebody has lots of other health issues, or if they're very old, and then it might make sense to talk about capecitabine. And however, in the trial that we're doing for Dynamic 3, we're saying, those patients, they might not want to do FOLFOX for 6 months, they might do capecitabine. But if you said your risk of the cancer coming back was 100%, they might say, actually, I want to do it in that case because I'm ctDNA positive. And so that's how it's trying to personalize it and give different options for different patients, but also being inclusive, thinking that not everyone is going to do 3 or 6 months. There might be people that do something a little bit different. Does that make sense, Michelle?
Yeah, thanks. Yeah.
And I have that paper in Colorectal, the graph where fluoropyrimidine plus oxaliplatin, the T and N stages. That's a very good figure for patients to have a discussion with their doctors for stage 3.
I print that out for most of my stage 3 consults, and I bring it into the room. It's so good. Figures are so good to discuss things.
Actually, I was thinking in my mind, because for some people, if you already know your genetics, you would already know maybe FOLFOX wouldn't work for you. So I was actually thinking, is it possible, like if you know the FOLFOX wouldn't work for you, is it possible to do something else as an adjuvant?
Good question. So There's a trial going on called IROCUS, which Canada and France are doing, and it's looking at FOLFIRINOX for patients who have T4 or N2 cancers that are resected. And then in Dynamic 3, which is our Canadian and Australian ctDNA, that's the escalation. If you were normally going to do FOLFOX, you'd go to FOLFIRINOX, and in Circulate US, they'll also go to FOLFIRINOX. Ideally, we would get some new drugs though, because I think it was nicely mentioned earlier. We've got this stable of drugs that we've really had for about 20 years, and trying to push the envelope and have more things would be better. Any other thoughts, Michelle?
Is any of those targeted drug possible for adjuvant treating?
So Manju was mentioning a trial that's happening at MGH after normal adjuvant therapy, and then thinking about, can we add in some extra things?
Okay,
Yeah.
so it's still a trial stage. I mean,
Yeah.
Normal patient wouldn't get it, and
Yeah, I don't think so. And I
Okay.
think that like the other issue is that to know if you're if there is anything targetable, you have to do some tissue sequencing, right? For
Yes.
early stage in general, it's not done. So you wouldn't know that you could use something because you don't get tested at that time
Yeah,
with early
yeah.
stage disease.
For Avastin, it wouldn't be the case, right?
Yeah, but I don't think Avastin is used in adjuvant setting.
Yeah, no, I've never seen it, but I mean, you don't need genetic
Yeah.
testing that I know.
Yeah, I don't think there are any trials, right? Do you know?
They were negative.
Okay.
Okay. Like the adjuvant trials, yeah.
Yeah, and then the other thing that I heard was, I think it was Atomic or Commit, one of them, they're trying immunotherapy in the adjuvant setting.
That's Atomic has that, yeah.
Yeah. So if that shows, but I mean, I'm not very happy with the trial design because they're doing immunotherapy plus chemotherapy versus chemotherapy alone. And they're comparing that, and which is like, when you had surgery and you really don't have tumor in your body, that is too much. So I don't know.
Yeah, 3 arms would have been good.
Yeah.
So this Japanese study is using the same assay, the Signatera assay, the same thing where there's whole exome sequencing. If you see WES, that's what that means. They make the panel specific to each patient, and then they were doing post-op testing. And then they didn't explain their schema too well, but it basically if you're ctDNA negative, you don't get chemo. It's to prevent the chemotherapy, the toxicities if you're low risk, versus CAPOX for 3 months. And then in those who are post-op positive, there's basically 6 cycles of, how did it work here? You get your 4 cycles of CAPOX, and then you get into a randomization of doing something extra. And I'm pretty sure this is TAS-102, or this is, there's a couple drugs that are available in Japan that are kind of different that we don't necessarily, this might be S1, I think, the acronym for.
Okay.
It might be, I'm not sure. I haven't seen FTD TPI. To me, that looks like TAS-102 potentially, but basically another fluoropyrimidine.
It's like Lonsurf is TAS-102, right?
Yeah.
Yeah.
There's a drug called S1 in Japan that's commonly used, and it's used in other Asian countries, but not really used in North America or Europe.
It's like 5FU, but without the bad effects. Isn't that the one?
Yeah, but maybe not without effects for certain groups. It depends on that. Part of the reason it was developed in certain places and not others was the metabolism is different.
Like the DPD and all of that.
Exactly.
Yeah. Okay.
They talk about kind of the genes that were selected. So you could imagine it's pretty impressive when you think about, they make a custom test for everybody. And so this was looking at the number of genes that are kind of used for each patient. And it's interesting, there are quite a few genes actually that were selected for only one patient, or particular, they said gene here, but I imagine it's the mutation, because I can't imagine there were 75% of things that were, colon cancer kind of follows it's a very stepwise. It likes P53, it likes APC, it likes KRAS and NRAS. There's certain genes that are usually there. And so they actually showed, there's a lot of diversity in what panel is being made for each patient, which highlights how much work this would be to make something. some different tests. There's different tests, and I think we've got a Guardant one coming up. Theirs is a little bit different, but some of them are not custom made for people, which there's pros and cons to each option, and we don't really know what's best. You could imagine if you had something that you didn't have to custom make, it might be quicker potentially, but it depends on how you're set up to do the sequencing.
I thought the IDEA study, they did some, like I think one of the sub trials in that, maybe France or something, they had done it, and it was 13%.
Yeah.
This is
most trials that I've seen, or most even retrospective cohorts, it's kind of like half of the recurrence you detect.
Yeah.
On the post-op one. Does that kind of match what you guys see?
Yeah. Yeah. So this is very high, right?
Yeah. And I was actually surprised that it was this low for post-surgery.
Yeah.
Interesting. This was a number of things looking at kind of clinical features that might be associated with ctDNA positivity, both this was the pre-surgery and this was after surgery. And so they were looking at, this was the different subtypes, like the histology. So this is, I think they meant adenocarcinoma by TUB. I think they meant tubular adenocarcinoma. And then I think this was signet ring cell, mucinous, papillary. This is a very rare type of colon cancer, and then unknown. So this was the histology, but it didn't seem like that mattered for whether you could detect it. It was really just the stage. And then the same thing after surgery. It was really just the stage that predicted. And then they did something called a multivariate. So when you do one of these analyses, you're just looking at, does that one feature predict things? But there might be something like a right-sided tumor is more likely to be mucinous. And so when you do a multivariate, you can you put all of this information into the model, and then it controls for it. And so you figure out, was it the mucinous part, or was it being on the right side that was important? Because there might be some sort of overlap. And so they showed basically that higher stage was really the risk factor. And there they showed a lot more that it was the T stage more than the N stage that was predicting, which I thought was a bit, the T4 is really high risk, but I was a bit surprised that the nodal status wasn't a predictor.
Mm-hmm. So it's like appending the AJCC classification, right? Where the nodal was more important than this T stage.
Yeah. So that was the pre-op, and then
I have a basic question about the staging, because I can't get around it. For stage 4, when you refer to the end staging, is it still the node involvement in around the primary tumor, right?
Yes, it is. It's just, it's often written as NX because sometimes you'll put the N if you've done the surgery and remove the primary tumor, but lots of times there might be big lymph nodes, but it might just be from inflammation. And so if the primary is still in and you haven't done that surgery, the X just means you don't know. Okay. It's like unknown.
But when you have, let's say, I don't know, if you have liver involvement, which is the most common, and then you have the primary tumor, and you have, in addition to liver, I don't know, retroperitoneal involvement, okay? And they open up the patient, they do everything like the 2 surgeries, primary and liver resection at the same time, and they do see positive or suspicious lymph nodes that then turn out to be positive in the retroperitoneum. Does that count in the end staging or not?
So that's a good question. The retroperitoneal lymph nodes would be considered metastatic lymph nodes because they're far away from where the cancer started. And so some lymph nodes there's kind of a guidebook to which lymph nodes belong to which area. So it depends where the cancer is in the colon. But if you had like a rectal cancer and there was a lymph node that was kind of closer to the transverse colon, that would be something that you don't expect. And so it doesn't actually contribute to the end staging anymore. It's actually used for the M staging. And there's an M stage for distant nodes that don't match the distribution that they should be in.
Okay, I wasn't aware of the M staging. Thank you.
Yeah, so it's T, N, and then M.
Yeah, so basically what you're saying is that the T and the N always refers to the primary tumor, and the M is for anything that is metastatic, including lymph nodes.
Exactly, yeah.
Okay.
Sorry, and I have a quick question, and maybe this is, let's say for someone that maybe only has lymph node disease, I don't even know if that's possible, but let's say they don't have the liver or the lungs, do lymph nodes shed ctDNA? Would that be able to, would you be able to catch that from liquid biopsies?
They can. One of the challenges is that lymph nodes are often they're often not that big, and so there's less tumor to shed stuff. And so sometimes it might be hard to detect. The other challenge is that sometimes we see big lymph nodes and it might not have cancer in it, because when a cancer is there, there's often some inflammation, and sometimes there's even an infection there because you've broken the wall of the intestine. And so the lymph nodes are big because there's an infection it's fighting. So sometimes it can be hard to interpret what's going on, but yeah, you could detect things from the nodes. It's just that they're so small, it might not be as helpful.
Okay, thank you.
They looked at the next figure that they have. They looked at the MTM, which is kind of on the Signatera, it's like how positive you are. It's a number that they give. So the MTM, so they're looking at kind of how positive they were, and you see that as the stage goes up, there's more MTM per mil.
Mean tumor
Molecules.
per
Yeah.
That's right.
Yeah.
Right.
Yeah, you're right.
Yeah. Which is a weird way to describe it, but that's the norm. That's how they do it. And then post-surgery, they were looking at what proportion was kind of positive or negative. And again, you see kind of this nice distribution. This is called a violin plot. Have you guys ever seen those?
No.
So there's a type of plot. So you see the boxes here.
Mhm.
That's called a box and whisker plot. And so what you're looking at there is this is the median. So we're kind of the halfway mark. And then this end and that end are the interquartile range. So the 25th percentile and the 75th percentile. And then usually the top of the line is the range. So the maximum and the minimum one. Sometimes it can mean something different. Sometimes they put the 95% confidence interval there. They don't describe what it is here, so it's a bit hard to tell. And then the violin plot is, I mean, they look pretty, which is nice. And they're more appealing graphically, but they're supposed to give you a little bit of extra information. It's supposed to be the density of the number of points that are there, because this is really helpful, this interquartile range, but there might be a different spread. And so it might look a little bit different, and it's trying to summarize the data for you differently. And so what this is saying is there's a lot of patients that are at the 0 mark, which makes sense. We kind of expect a lot of patients at that end. So, but you wouldn't have necessarily guessed that if you'd looked at this interquartile range. So it's trying to give you a little bit of extra information. And when you see a curve a thing that looks like this, where it's really tight like that, it means there's not much distribution. So they're all kind of about the same.
That I heard from Signatera, like our general, that, because they tailor make the 16 mutations for you, and they're looking at those, what value you have just really tells you how good that PCR was able to detect the sample in your blood, rather than, and comparing it with somebody else's test. Whether it was really like, if I had a value of 80 versus the other person had a value of like 8, whether, you could say that I had more cancer than that person, whether it was really okay to say that, because it could mean that the 16 chosen, the cancer that came back had like, I don't know, 4 or 5 of those genes, whereas in the other person, right, it could be 10 of the genes were picked up.
Yeah.
So I don't know how.
They do let you know when they can't find the 16 matches for your particular cancer. So basically, if you get less, so the minimum, this is something that I asked specifically because my husband's test came with only 11 pair of primers, and I was like, what is this? So basically it means that they couldn't find enough variants in the tumor that are different enough from your germline. So they can't filter it out. So they keep those 11 in his case. The minimum to accept the test would be 4.
Yeah, that's what I heard.
4, yeah. And then, but they say that over 4, basically, the sensitivity can be compromised. And they put that as a warning. But my understanding is that because you had less pair of primers or less mutations identified first, and you can be losing some over the course of the history of the cancer and the changes, then you are at risk of not detecting it at some point.
And I was kind of wondering that because you're on a clinical trial, there you got that information, because I don't think that the reports that we get say that, that how, only 11 were available. I was kind of wondering. Or it could be possible because
the thing is that this is the standard report. But
Okay,
this is
and-
my understanding. I don't know. We don't get it as the clinician that gets it, but it comes from Natera and.
Yeah, maybe I've only had negative results, so maybe that's how I don't
Okay,
know.
I'll share it with you then, so you can compare what we get to what you see there as well. Yeah, it might be that here they're giving us a little bit more information, but what they do, what they said, like the specialists from Natera, is that even though you can't compare like from patient to patient, and I think this is what they knew when they were commenting on the levels, is that they see most of the patient around 10 mutations per milliliter. That would be like for stage 4, this is again oligometastatic disease, they would see most patients around 10 per milliliter, so 10 mutations, mean tumor molecules per milliliter. And I think that plot shows it very clearly that most of the patients, you can have some, you know, but that are lower or quite high, but most people would be around that value.
It's a good question about what is the right number of mutations to detect. You know, there's different companies that are coming up with their, like, there's one that has a lot more. There's some that are coming that have less. And there's probably some cancers where it really matters. And then there's some cancers that, colon cancer is actually pretty consistent in the types of things it gets. Maybe not as much as pancreas. Like pancreas, 95% have a KRAS mutation. And so you know that there's not a very good chance of losing that KRAS mutation. There's a description of that for colon cancer. It's called NeoRAS, and it's kind of just being learned about. But we don't really know what's the best. And if 11 really matters versus 16, and I think that's something that would be great for us to learn more about. Hopefully we'll get there. But
yeah, and I think that like they said that they were looking at truncal mutations, and they were not going after anything that is likely to change due to treatment. And so, I don't know. I'd really like to see their panel, like the other paper we saw, or maybe it was here, right? They said that the common, there was a table. Yeah, this one. It would have been kind of nice if they had like shared that with us, right? Like the common 25 genes that commonly are used in a panel for Signatera.
some of the other companies, they just do 15 and they get very similar. That's their like kind of starting point, and they only do colon because colon is kind of easier from that respect. Whereas some have, they're not as similar. Not all, there's lots of difference in colon cancer, but maybe there's some types of cancer where they don't all look kind of close. So it'd be nice if they shared that. I agree. Hopefully we get that at some point. But that's kind of the secret sauce. I don't know.
Yeah. So the last table was really interesting because they talk about the MTMs for each tissue, the tissue, or no?
Oh yeah.
Yeah.
Patients with the recurrences, and they were almost all of them except for 2 were positive, and there was one that was negative the whole time, which is a lung.
Yeah.
Because the recurrent site, and then one that was a peritoneal, ovarian, and local recurrence that was negative initially and then positive at 12 weeks. Most of the recurrences are very early. The median follow-up time, though, is only 4 months. And so it's a bit hard to know. They just don't know about many patients. They haven't been on it very long. So it's a bit hard to interpret.
Mm-hmm. And then again, the thing is that do they say how often they do the CT scans? Maybe they say it somewhere, if it was every 3 months or something.
I don't see it in here. I'm not sure what they did on the protocol.
Because I think that's the only place when they can know that, you had ctDNA at this time and the next scan, right? So it looks like from their time, it's all very few, like nothing more than like 6 months.
Yeah. It'll be nice to see when at the next year's, they'll have a little bit more follow-up and we'll see what happens.
Yeah.
I have a question. Continue earlier, you guys were talking about how many genes different companies are looking at. So I know Signatera is comparing the tumor tissue to pick several mutation or genes, but the other companies, they are only looking at the blood, right? They're not comparing with your tumor tissue, right?
Mm-hmm.
So when you guys talking about the 15 genes, so they are only looking at the blood if you have a mutation in those 15 genes, right?
So some companies are looking in your tissue and then making a custom panel, because it can be different spots within the same gene, and then they make a panel kind of like Signatera, where they do it's a PCR or digital drop of PCR, something personalized to the patient. And then there's other ones that are just blood, and they have kind of a panel that they figured out if they've got this combination, they can identify most patients with those cancers. However, many of them also add in something called methylation.
Mm-hmm.
And so those aren't mutations, they're changes. Basically what methylation is it's kind of the thing that turns on and off genes. And that's how our body regulates what's going to happen from a gene. If a gene is methylated, it usually is kind of asleep and not turned on. Mm-hmm. And then the green light is when the methylation is not there. And so this there's patterns that are different for different types of cancers and from normal versus cancer. And so a lot of the tests, like the GRAIL test that's for screening, it uses a lot of information from methylation. Usually we don't know all the information for some of these commercial tests because they don't tell us what they're looking at for the specific details, but they tell you it's mutations plus epigenetics.
Yeah, because I kept wondering, like, what's the sensitivity? Like, there's all different companies that have their assays. Which one would be better? You know, that's a hard question. But if I just think about that technology, the one like Signatera, they're comparing with the tumor tissue. So for the others, they only look at the mutation in the blood. I would imagine they would get less information, right? If you don't have a RAS mutation or RAF mutation, you may never pick it up by only looking at the blood, right? But it's like if you compare with the tumor tissue, I believe those genes that picked up are not just oncogene, not just those well-known. They could be passenger mutation only exist in your tumor, so you would be pick up more things. What's your opinion on this?
I think the jury is out and we don't know, because a lot of those tests have other things that might be advantageous to them. And so they're just different technologies, but it's going to be really interesting to see where we land if there's all these trials that are done with different tests in different settings. And what do we approve? What do we order? Do we order Signatera or Guardant or Coca-Cola or like they're all going to be a little bit different, and it's going to be hard to know. And I think it's challenging as a clinician, and it's going to be challenging as a patient as well, because a lot of these are things people pay for. And so
yeah, I think at least in Town, in general, so far, I mean, we don't have, so Guardant Reveal is a new test from Guardant. So they have something like, they look at certain mutations, and they also have methylation markers. I think they're using 3 gene methylation markers, and they're just brand new. So I think they're out from May, and we don't have too many people using it, but it seems that they're not as sensitive as Signatera. So this is, you know, anecdotal, non-clinician. I mean, we are more free to talk about it than you are, right? So far it looks like tumor-informed Signatera seems to be the best. And then I don't know, like we need to have so many people do Guardant to know how it is working, Guardant Reveal. But Guardant 360, we have seen in Town that it's not. With many people, especially if you're on chemo, many times Guardant 360 is negative. So that's not very useful. And in general, we kind of say that if your CA is rising, and then you know that you're having progression, then you can use Guardant 360 to see what is new in your tumor, and it may likely be positive. Right? Do you want to talk about your poster so that we can?
Sure.
Yeah.
I think, Natalia, did you have something you wanted to add?
No, I think that the original papers where they started the cell-free DNA isolation and characterization, and most of them were somehow connected to what they ended up being the test of the companies. Initially, what they described was that the sensitivity of the tumor-informed was superior to the tumor agnostics. And I think it has to do with what Michelle was saying. Right now, I think in the real world, what we need is a direct comparison that is not sponsored by companies, to really know,
Agreed.
because no, but that has been done, let's say, with even with the tumor tissue, you know, and the Foundation One and Guardant and all of them, and it was interesting to know how much overlap you were seeing with the different companies, and I think eventually we will get there with this.
So this was a poster that I presented at ASCO. This was I was at MD Anderson before, so it's with a number of collaborators there, but collaborators at a number of institutions as well as collaborators from Guardant. And it's looking at patients who had serial tests in the global database. And so, you know, we don't really know if getting a Guardant 360 every, 6 months actually finds something new or doesn't find something new. And so that's really important, because we might find something new we can target. And on the other side, if we don't find something new, then that's also important to know that it might not need to do that test. And so we've spent a lot of time talking about the different types of tests. And I think it's really important to know before you buy it what your test is geared towards. So there's kind of the minimal residual disease tests, like the Signatera, where it's meant to find just a tiny amount of DNA from microscopic disease. And then there's the comprehensive genomic profiling. So you're trying to find lots of different genes, lots of things you can target, but there's probably more DNA floating around because you're looking broadly instead of really small. Because if you're looking for a needle in a haystack, which is really what the Signatera and the MRD assays, you often spend a lot of your sequencing looking at one spot over and over again to make sure you're really comfortable with it. But when you're doing like a 360 or some of the other bigger panels, or the new kind of what'll happen for Guardant, like, you want to know about all those different genes. You want all that extra information. So it's just a different approach. So we looked at 501 patients who had at least 3 Guardant 360 tests over a 5-year or 4-year time span, and looked at mostly the actionable changes. So the things that would actually impact care. So MSI status, ctDNA, not all ctDNA tests can pick up MSI. It's becoming a little bit more frequent that you can. But we saw about 4.2% of patients had microsatellite instability detected. That matches kind of what we would expect in the stage 4 setting. But there were some patients who had, who did have newly detected MSI. So out of the 17 patients, there were 6 that had newly detected MSI. Probably just that there wasn't enough ctDNA before, and it's not necessarily that the tumor gained MSI. That's not really described. But that's helpful to know that it might be worth sequencing to find some more. And then there were only 3 out of the 17 where they couldn't, there was an assay where it was detected and then it was lost. And so that could be because of a lower amount of DNA, or it could be some sort of change in the tumor. Again, we don't really think of MSI as something that changes over time, but just kind of describing what happened in the cohort. And then there's 7 patients where it stayed the same, 7 out of the 17, and 1 patient, they only had 2 assays that were MSI high, like able to test that because it was a change that happened in the assay. So we couldn't really assess what happened if it was stable or not. What was interesting, when you get the report back, you see the allele frequency for some of the tests. Like Guardant always gives you the allele frequency, which is really helpful. And so you could see MSI even at a really low level, so 0.5% VAF. And this one was one that changed. One of the things with MSI, though, is it could be in normal cells if someone has Lynch syndrome. And so there's a chance you could detect it at a really low level, and it might not be from the tumor. It might be from their normal cells as well. And so that's something to know about. We looked at fusions. Fusions are super exciting because there's all these new drugs that are coming, like the NTRK inhibitors, RET inhibitors, FGFR. And these patients who receive them, they have really exciting responses. They're usually pretty well tolerated drugs. And a lot of people have these kind of Lazarus type effects where it's a really big change. They're not that common though, which is the really hard part. So we saw 9 patients had a fusion of any sort that was detected. And basically 3 were always there, 3 were newly detected over time, and 3 of them actually weren't detected later, but at some point initially they were. So pretty variable between the different tests. This could be, the ones that lost, these ones were all NTRK. Actually, only one of them was NTRK, but another was an ELK, another was a RET. These are all things that are targetable. So there's a chance patients might have received a drug that got rid of that clone, so those cancer cells that had it. And then some of these ones that we see, these could potentially be resistance to something. Like if someone got an anti-EGFR drug, and then they got a fusion, that might be how the cancer cell kind of escapes. Any questions?
Yeah, I was kind of wondering that in these kind of tests, it would have been nice to know what is the total amount of ctDNA detected, because then that could give you some kind of baseline, right? If you got like X amount and then you didn't detect any mutation, then you know that the test actually worked and you were able to detect whatever amount of ctDNA or whatever amount of circulating DNA, right?
Yeah, you just need to know that it's from the tumor and not the normal stuff.
Yeah. Because we have patients, where the VAFs would be really, really low, but then it might be an interesting one, and like if you see a BRAF or a KRAS G12C, something like that, then you wonder whether they should be on targeted therapy if it is like 0.1%. It's just so low. But if you knew that the total tumor DNA detected was also like 1%, then you know that that is significant, right? But if it was like 50, then 0.1% is really not of any consequence.
Yeah, so we describe that as the relative variant allele frequency. So you just take the mutation and divide it by the maximum one, and that's kind of a measure of how much tumor there is.
Okay.
So it's a good point. You don't want to attack the things that aren't really there in much of the tumor.
And I assume that it would be too much to do it in one study, but I imagine, do you see any correlations when you compare the liquid biopsy to what it is, the sequencing or the pattern that you see in the tumor? Because I remember chatting with other patients, and when you're in the setting of the oligometastatic disease, you're picking the metastasis that is accessible. And then, okay, this is because maybe of my scientific background that I had this discussion with the oncologist. Maybe I was in an ideal world, which is not the clinic, and I was like, can you not take samples from all of them? It's like, because not all of them are going to be the same. And he was looking at me like, well, you can't do that, but so how much do they correlate? And if you have the choice of going for one of the liquid biopsies or the solid tumor, if it is accessible, if you have tissue, which one would you do?
We don't really know the answer to that yet. I would say they are highly concordant for the things that you need to know. So like BRAF or a KRAS mutation, they're really good studies looking at biopsy a lung met versus a liver met versus the primary, that it's quite concordant. Sometimes the lung is a little bit less concordant. That can be, a little bit of that is lung biopsies are often smaller biopsies because you worry about a pneumothorax, and so you might have kind of a false negative. There's also sometimes lung metastasis, except for rectal cancer, but for colon, that might be something that's later, so there might have been more change in the tumor. But it's highly concordant between the primary and those different metastatic sites for the things that are kind of you need to know for current things. For some of the more experimental things, there might be more variability, but KRAS, NRAS, BRAF, MSI, those are things that are pretty stable over time. The ctDNA, you run into the challenge of, what if the test comes back negative because there wasn't enough ctDNA floating around, and then you spent the money, but you didn't get any information. So then if you've got a negative test, you don't have the KRAS, but you've got a P53, then well, at least it picked up something. So I feel reassured that, that it picked up something, and I'm probably wild type.
Sorry, I have one question. So when you're talking about like it picked up these like NTRK fusions or things that are really exciting because there's now targeted therapy for them, are you saying that these things are not picked up in the normal tissue biopsy, and therefore this study is trying to pick them up with this liquid biopsy? Like I guess I don't understand. If you already have the tissue testing, is this just so you don't, because tissue testing is to get it continuously is more difficult?
Yes. So you may or may not have this information depending on what the panel that was done on your tissue tested. Same thing for the circulating tumor DNA. They don't all include all the same information. So some patients might only have information about KRAS, NRAS, and BRAF, single gene testing. Other patients may have a panel that picks up certain NTRK fusions versus other ones. The reason we did this study was to look and see if there was much change with doing serial tests, so subsequent ctDNA, because that's a big investment for patients to do, and to see if we were able to actually see differences and how that related to the allele frequency shifts. And as you said, it's hard to biopsy multiple tissue sites because it's painful, there's a risk of complication. It's also very expensive to do a biopsy, as opposed to a blood draw is quite easy to do.
Okay, thank you.
And then the other thing that I heard was, like, for example, we have a about 300 member BRAF group in Colin Town. So in general, what we've heard is that, like, because they have the targeted therapies available for them, in those patients, like, we recommend that they do Garden 360 at every progression, because, if they have been on the Beacon doublet, we see BRAF amplifications and things like that at progression. And for them, it makes sense. Like, in general, that's kind of what we're doing. So I don't know whether, if you're on chemotherapy.
What are they doing with the information?
They're seeing whether, if they don't have too much BRAF, or they can see, like, because the next step, most people, what they're doing is they're going back to chemo. So in general, what we suggest is, like, people who are on targeted therapy, not to go to another trial with a different targeted therapy, than have like a couple of cycles of chemo. So what seems to happen is, like, if you're on a BRAF targeted therapy and you have like a lot of BRAF amplification and it's not working, then that time over chemo is supposed to decay that amplification, so that the next, if they go to some other, SHP2 inhibitor or something like that, then that the chances of it working is higher. I mean, unfortunately, it's all theory, because, because it being so aggressive, we don't have patients who have gone through multiple trials and chemo, living that long. I mean, so yeah, that's why I was curious that, like, this is like a pooled all different cancers, right? Not CRC alone.
This is just CRC.
Just CRC, okay. But then it's on all kinds of treatments, right? Not targeted. Yeah, okay. Yeah.
So the detection of the fusions really corresponded to the change in the maximum detected allele frequency. So on your report, if you see a couple different genes, there's always one that's kind of the max. And that's probably how much ctDNA there is. That's kind of a surrogate for that. And then loss of that detection, we saw that in two-thirds of them, it was really when the allele frequency was less than 1%. So it might be that there's still some cells hiding somewhere. It's just that the ctDNA level is not high enough. So it doesn't necessarily, in that case, it doesn't necessarily say that the clone is gone. It might just say that they're suppressed and there's not as much ctDNA around. And then we also looked at amplifications, and amplifications were quite interesting. So about half of patients had an amplification in a gene that we thought was of interest. So we've got a list of the different genes, and the new detection of an amplification most commonly occurred with a rising allele frequency, and same with the loss of a detection of an amplification. But what was kind of interesting was that HER2, ERBB2 is the other name for it. When you look at kind of the serial detection, a lot of them kind of stay around, and HER2 is one that we can actually target. There's a couple of trials, and then it's also in the NCCN guidelines, before the trials have been fully, and there's dacatinib, there's a whole bunch of different things that are coming for this. And so the fact that it was quite stable for HER2 is reassuring that you might be able to find it and then know that it's there and act upon that information kind of early on. Whereas lots of the other ones, it was something that might be detected subsequently. So maybe it's as Manju mentioned, a BRAF amplification because they've just been on a beacon type drug, encorafenib, and that's how the cancer got away from the resistance.
It's kind of interesting.
Do you mind, so does NRAS mean, because I'm an NRAS person, does that mean you had no one with the amplification in your study?
Yep.
At 0?
Yeah.
Okay, NRAS gets no love, but.
Or it doesn't get amplified.
Yes. Yeah.
We are also NRAS.
Oh. So too, but is it amplification or mutation?
This was just amplification. It wasn't about the mutations.
Yeah. But
what is the difference? does that mean how much your mutation is amplified?
So it's a mutation means you could think of it like a recipe book. And so if you have a mutation, basically one of the pages in your recipe book has something changed. And so you were supposed to make a pie and then, you changed one of the ingredients and that has screwed up the whole recipe and it's not going to work. And so that's how that cell works, is it's got all these recipes that it needs to make. The alternative is an amplification, is basically you took and you just duplicated that recipe like 100 times. And so the recipe book has way too many copies of that and you're just going to keep making too much of that. So amplification means that there's going to be too many copies, and usually it just means there's more of the normal. Sometimes you can have amplification of the abnormal. So a mutation is when there's the word spelled wrong, and you can have too many copies of that, but it's a little bit more common to just have too many copies of a normal thing.
Okay. Yes.
What it means in these tests when they say, let's say, make amplification equivocal.
Means they're not sure.
So they detected something that looks like you have more copies compared to the normal, but they're not sure.
They're not sure.
Okay.
One of the challenges is in the blood, if you have a low maximum allele frequency, you don't have very much ctDNA, it's hard to find an amplification because you've got all this normal stuff there. Because your normal cells they have a certain copy number.
Yeah, because I've seen that coming out a lot more in liquid biopsies compared to the reports coming from tissue. And I was always wondering why is it that they always put equivocal? And it's like, okay, makes sense.
Yeah. And then we looked at the number of SNVs. So SNVs are the mutations, the words that are spelt wrong, basically, and looked at how many of the serial tests had an increase or a decrease. And it was kind of a third, a third, a third. So a third of them had more SNVs, a third had less, a third had no change. Most of them had very minimal difference between the different assays, but the maximum was a gain of 21 different things, and the max loss was loss of 18 things that were detected before. And so there's a pretty big spread, but the majority don't have a change, which I think is helpful to know that, if you're going to have a change, it might be one or two things that might be different for most people, but some people are going to have more. What was interesting was that, again, we saw that the same thing, that really ctDNA level is really important for what you're detecting.
Would the MSI high status have an influence on this?
I mean, those are usually the patients who have like a 21 or an 18. Okay. There's very few people who get a garden back and have that many alterations without MSI.
Yeah.
And then this one, it's a kind of looking at the same thing. And so we're looking at the new detection of the SNVs. And we were also looking at amplifications, and the amplifications were a little bit less associated with the max SPAF than the SNVs, but this is kind of the overarching summary. When you look at the 501 patients and you look at how many have something new, most people, if they were going to have something new, they had a new SNV, so a coding thing. Some people did have a new amplification detected at some point, though. And only a few people are going to have something new that's MSI or a fusion, and about a third are going to have nothing that's really substantially new between them. And so I think this is helpful for thinking about the test as far as what you're going to do with it in the future. I don't think it necessarily changes if you're going to order a subsequent test. I think where I would use this more is, if you don't have very much found and then all of a sudden there's a lot more tumor in the future, that would be helpful. But I think this gives more support to, if there's less tumor than there was before, you're probably not going to find more. And this is just looking at the number of new classes. So we call each of these a different class of mutation. And so about a third had no new class. About half, they were only going to have one class that was altered, and then 2 classes were altered in about a quarter of patients. So just kind of giving kind of a 30,000 foot view of where we are.
Do we have any idea, let's say if you have a patient who's undergone surgery, chemotherapy, and so on, was using, let's say, Signatera and stayed negative for a while and suddenly starts being positive again, So you don't have tissue from this new recurrence. Would it be possible to do one of these tests to see if there is a change? But then the question is, you have a positive ctDNA from an assay that is supposed to be more sensitive. When is the right time to take blood to do this other liquid biopsy and get the genetic profiling of what it would be an actionable mutation? Because I suspect that when you have a positive Signatera, let's say around this 1, 2, 3 mean tumor molecules per ml, probably this doesn't pick up anything.
I think that also depends on what your question is. I mean, ideally, Signatera would tell you what your panel was made of, and then you would have all these early stage cancers would know their KRAS, NRAS, BRAF status before they relapsed. And those things really aren't going to change, in which case it would be, well, if you're going to do the same first-line therapy anyway, why would you want to get a Guardant 360 up front? Because you have the information you need, and maybe you should spend the money and do it a little bit later after there's been some treatment and you might have changed things in the tumor, if that's the time.
I'm thinking, for instance, in someone, I don't know, we have cases in the community where people have done panitumumab or cetuximab before surgery and everything. They reach R0 in resection and everything, and then they have a recurrence, and some of them have tried, re-challenged with those same EGFR inhibitors without having any testing done. I guess that it would be an opportunity where you can use this test to see if you have some kind of resistance in these new clones that are arising afterwards, or would it be unlikely?
So there was a nice poster that Christine Persigian did that was looking at the development of those clones, and you don't tend to see them develop as much if it's with like doublet chemo plus the anti-EGFR. But if you're doing just cetuximab or panitumumab by itself, you tend to develop those clones. And she's published a nice, you see the half-life of those clones. They tend to decay with about a 4.5-month half-life, and so you could kind of try and use some of that information to guide you a little bit. And I'm not sure that you would, I'm sure there's some patients where you'd see the mutation and that might inform you and say, oh, maybe I'd go with bevacizumab instead of panitumumab with my first-line doublet. But I don't know how many patients it's going to change things. I think that's probably the perfect version of medicine would be that you'd get that continuously. It's just thinking about how much.
It's good to know because sometimes from our side, we think that, okay, if we accumulate more information, you have better chances, and maybe you're just spending money waiting for the results to come back, and it doesn't make a difference. Yeah.
They have the Chronos trial that was presented at ASCO. So where they looked at ctDNA, those who were positive, and then they gave EGFR inhibitors, and then they went on to another therapy which did not have EGFR inhibitors, and then they looked at ctDNA again, and then they were trying to see if you gave EGFR inhibitors again, what is the response rate? And I thought it was really interesting how they use ctDNA to do that. And they were finding that like even the second go around EGFR inhibitors did work for a subset of patients, and you could predict who they were based on the ctDNA results. It's a small, I thought I was really excited seeing that, because that would be the kind of studies with ctDNA that could be done, and like tailor-make things, right? That would be kind of cool. Yeah, I thought that, Natalia, I thought that what you were really asking was that if with Signatera you had MTM levels to a certain number, would that help you decide that this is a good time to use Guardant?
Yeah, that was my original question, but the setting would be, what is Guardant also adding to the treatment? If there is no real difference and you're not going to pick up anything new, really, like the first question isn't valid anymore, right? But in the case that you were expecting changes, then the question is, okay, you have Signatera. Signatera doesn't give you any information about what is actionable, not even if you ask them, like they say no. So then it's, okay, you need to go for the Guardant. When would you do it? Just right after, I'm thinking from the patient perspective, you see something, you want to do something because you feel that you're more in control, but you also have to have a good timing, because sometimes anxiety takes you to a rush decision, and then if you're running the test when you don't have enough ctDNA.
Yeah, it'd be kind of nice to see, like, if you started with like 2 MTMs and it became 50, maybe that might mean that there is more ctDNA being released, that now you use Garden, maybe you'll see something. I mean, I know that in Colorectal, there are some people who are determined to do both Signatera and Garden. We have that population. So it might be a good idea to keep an eye on them and see what they get and when it matches, that'd be kind of, and again, but I don't know that because the test really is like the panel that is working for you is what gives you the number, right? So that's what makes me wonder how does that correlate with the panel that Garden is using, right?
I also think that it wouldn't really add a lot of value because they're gonna, it's amazing how quickly things are moving. And so, the Garden assay today is probably different, even if it's still the Garden 360, there's something, they add 2 genes, they change something, but the sensitivity is probably also changing. So I think that would be perfect if it was kind of static. I just think the world, it keeps moving, and the Signatera is the same thing. I'm sure there's lots of R&D that's happening in the background that we might not necessarily see. So it'd be hard to know those numbers.
Yeah, and then the other thing is that Signatera just added the Altera. So maybe you should ask your trial people, because what they're doing is that they are now giving you genomic DNA information. They just started it recently.
Altera, isn't it in Tumor?
Yeah. So
okay, in the original sample that you sent, I presume. Yeah. But
they'll give you the result?
Yes, they'll give you the tumor testing result. So it's almost like Foundation 1 plus Signatera.
Yeah.
But then you have to pay extra. So the physician has to order the Altera.
But they've already done it.
Yeah. But that's what they're doing. So now when they have a new patient, they ask you, do you want the Altera and do you want the Signatera?
It would involve reprocessing probably, because the way they filter out the variants is, so the type of analysis they do on the information is different if they want to give you information about targetable mutations compared to, but yeah. Just a quick question, going back to the results of the poster. Did you see, maybe I missed it, sorry. Did you see any correlation with the appearance of new variants in terms of how heavily treated the patients were? Like how many lines of therapy? Is there a correlation there?
We didn't have treatment information, so we couldn't really gather that because it's from like this global database, but we don't have access to all the info. That would be nice, yeah.
So John, you have spent a lot of time with us. Thank you so much.
Yeah,
it's almost 2 hours. And I hope that we were able to give you some information that could be useful.
Yeah, definitely.
Yeah, thank you so much for your time. We know how busy you are, as a doctor. And so for you to spend this time with us really means a lot. And we hope to share the information that you shared with us with a lot of young patients that we're working with. So thank you.
Yeah.